Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. The college is currently finishing its holiday break. During this period, our Friday podcasts have featured the highest-rated monthly Quorum Webinar Conversations episode from 2025. This week's episode revisits the discussion on nutrition in prolonged casualty care. We review the JTS CPG on the topic and spent about an hour discussing it with students and college members. This is the final special holiday podcast. Next week, we return to our regular weekly podcast series where we meet some of the movers and shakers in the austere and academic medicine community. Now, let's turn to the conversation with Bill Vasios, Rhod Jordan, and me as we explore the key themes of this important publication. So, welcome to the Nutrition in PFC CPG. You have three of us who will be presenting. My name is Aebhric O'Kelly. We have Bill Vasios, who's a physician's assistant, former 18 Delta, and Rhod Jordan, who is a remote medic who is currently on the job in somewhere sandy.
And still pleasantly warm.
This is the Quorum Conversations, and what the three of us are doing is going through our CPGs in a stepwise fashion, and we have gone through our March algorithm. So we have been going through the March pause or the CABC algorithm, but now we're down to nutrition, which is not part of March pause at all. It's prolonged field care. So for us at the college, we use the Hitman mnemonic and the sheep vomit, which is part of the end of nursing care, and the ins and outs are under the nursing care. So we're going to talk about the ins and outs of nursing care. I'm going to follow this CPG, but I also have added a very short bit from the prolonged field care CPG. So on page 44 of the prolonged field care CPG, they talk briefly about nutrition on all four levels, the ASM, the CLS, CMC, and the CPP level of the TCCC. And the minimum is if the patient's alert, you can give them food. Better would be using protein powder, and the best would be commercially available tube feeding products, which we don't have at all. And then special nutrition requirements for burn patients. And that's something we'll talk a bit more about as we go through. So definitions. Bill?
Well, so when we're talking about giving food to a patient, there's two primary routes. One is enteral and one is parenteral. And we discussed this in our pre-meeting. We want you guys to understand that when you're learning how to do anything in medicine, you need to be able to understand it so that you could process it and utilize it in the treatment for your patients. But at some point, you're going to have to explain something to the patient, a teammate, a family member, somebody that's not medical. And so you need to understand it in layman's terms, if you will. So enteral is basically we're using the patient's own digestive system, and we're getting access either orally, where we're handing them a sandwich and they're going to eat it, or we're going to put a tube in their nose or their mouth so that we can give them food supplementally that way, using their normal systems of the stomach, a duodenum, jejunum, to provide nutrition for them. And then when that fails or it's contraindicated, then we can give total parenteral, which is we're using it through intravenous methods. So overall, if you had to think, and this is a discussion, so that means you're just putting information towards you, you're throwing stuff out here. So what are some of the benefits of enteral nutrition to a patient?
Keeps the blood glucose up to the levels.
Okay, so glucose, right? So nutrition, glucose, energy, right? There is, go ahead, Connor. Say that you've raised your hand.
It is morning over here. One benefit I could say would be it's less invasive, so less risk of infection.
Okay, that's good. I think definitely a benefit by using the body's own normal system of receiving nutrition and processing it, right? There's less complications, less side effects, less infection, less requirements. What about benefits of starting early or late? What does that do for healing? Now, we're making the assumption that you guys have seen the CPG or briefly read through it, or you're just pulling on your generalized experience and exposure in history and medicine. Blandon, yes, it does improve healing because it starts giving the body requires energy to recover. And so what they want you to do is start feeding early within, the CPG says within 24 to 48 hours, which is a very broad time frame, but there is some caveats to that. Yes, improves clinical outcome. It could help warm the patient depending on what kind of food you're given. Reduce secondary infection. Yeah, these are all good things. If you want to, Aebhric, bounce to the next slide.
Well, there was a hand up. Muhammad, you had your hand up.
I wanted to say about the psychological effect of the eternal feeding as well. Like the patient it has more improving sort of self, like when the patient can get his own needs by eating whatever consume energy, it does have a better psychological effect on improvement from a perspective of the patient, because it thinks like, yeah, I'm getting better, I'm eating, I can kind of do one of the most important things that we have to kind of consume energy, intake energy from eating. So perhaps psychological effect of the positive influence of the patient, that could be one.
I think that's a hugely valid point, Mohammed. We referred to it a couple of conversations ago because it gives the patient an element of control over their own self-care. So you're enabling them as well. The psychological and even very positive physiological reaction to that self-care is immensely important. Thanks for raising that one.
Yeah, Blandon made a comment in the chat about morale. So yeah, it's encouraging that you're well enough that you can consume food on your own. And if you're unable to do it through uninsecure airway or in and out of a consciousness, then you're at least being fed, and so you're sustaining it, reducing the infection, early healing, that kind of stuff. So it's all good. All right, you want to go to the next area? So like some of this has been mentioned, decrease infectious complications, reduce hospital and ICU length of stay. Definitely benefit when you start early. This is kind of a two-stage, right? You're going to have a patient, and we have to think of the environment that we're in. It's an if-then. If my patient is going to be in the ICU or in this situation for 5 to 7 days, then you're going to have to provide nutrition for them, enteral or a parenteral. And then if you make that decision, then you need to start it early, because it does reduce the healing. It reduces the stay. It improves condition. All of those things that we discussed, improves healing, right? So there's maximized benefit if the patient needs it, that you start it early. So it's an if-then kind of thing. And even if you do hypocaloric, which we'll talk about a little bit later, that's better than nothing, because they may not be able to sustain normal volumes based on their condition, which could lead over into the contraindications that we're going to discuss in a few slides. So we're going to focus this mainly in the austere environments. Enteral helps reduce the logistical requirements and complications, because it's a lot of the stuff that we may have access to. I don't think I've been on a deployment where people didn't have protein powder or supplemental drinks. So, I mean, it's readily available where we are. And I think we discussed in the pre-talk that we figure out what kind of powder or, supplement that you have available where you are. And then you do an early teleconsultation with a nutritionist to say, hey, this is the box of powder that I have. How do you recommend that I give it? But we can get into more details on that later. All right. So when do you feed your casualty? We kind of discussed, you determine that they're going to need some type of supplementation nutritionally, and you're going to start it early. So when would you feed your casualty? Give me some conditions that's going on with your patient. Well, what kind of medical conditions? Trauma, burn patients, TBI patients. There you go. I mean, those are the big three that we're going to see for the most part. Different traumas, different burns, different TBI kind of stuff. So those are honestly the big three for us. You could have septic patients, depending on what their level of resuscitation is, which may kind of go into the contraindications, depending on how sick they are. So the next one, when would you not feed? Like, how sick would they have to be for you to not feed them? It seems kind of counterintuitive. Okay, so if airway's not protected, then you could still protect the airway with some form of definitive airway control, and then you could put an NG or an OG tube in, right? So that's not a true contraindication, right? You wouldn't give them a sandwich to eat, but you might put a tube in their throat and their stomach. Okay, if they're actively vomiting, choking or aspiration, you can secure an airway. So, I mean, you're going to do this stepwise. It may not be something that you start right now. Like, you've determined that you're going to keep a patient for at least 5 to 7 days. That person is going to need nutrition. You want to start it early, but they have these things going on, like vomiting. They have all these risks. So you're going to isolate all of these problems on your problem list, and then you're going to come up with a plan to secure the airway, to secure an NG or OG tube. You're going to consider the consultation for a nutritionist, and then you're going to figure out what type of food is the best way for you to provide nutrition for your patient based on what you have available and what the consultant says when you reach out to them. So in case of trauma, abdominal or GI bleeding, okay. Yep. If the patient is self-aware, even if they're not, I mean, if there's a list that we talk about soon where it gives some hard numbers that you wouldn't consider it, but just in general, if your patient wouldn't be able to function, and this is totally a word, gastronomically, if their stomach and bowel movements are not going to be functioning properly, then the last thing you want to do is put food into that system. If they've got an ileus, if they've got an obstruction, if they have too much pressure and you're not going to have peristalsis, like all of those conditions that would slow normal gastric motions, you don't want to add and complicate to that problem, right? Don't make it worse. I am pretty sure that there's a saying in medicine about not causing more harm, right? I may have read that somewhere, right? So any of those normal conditions that you would be worried about somebody's gut motility, then you don't want to put food into that situation, right? And so, yeah, Rhod, you talked about MAP, right? So go ahead to the next slide. So why would a MAP less than 60 be concerning for giving somebody parenteral or enteral nutrition? I mean, what does that mean? Right? How is gut motility when somebody's in significant shock like that? Go ahead, Sven.
I mean, they wouldn't be able to process any intake. They're just centralized, so the stomach wouldn't be active.
Right. And so, you're going to make your global assessment of your patient. Are they sick or not sick? Are they stable? Are they unstable? All of those things are going to go into your assessment of how your patient's doing. And if they're really sick and unstable in some form of shock, whether it's any form of the shock, or that their normal system isn't going to be moving, blood flow to the intestines, all that stuff, if they've got an ileus or an obstruction or an adhesion, they just recently had surgery or the history of complications. There's all these reasons where you'd be concerned about it. And then part of that would be in your teleconsultation call to a surgeon or a nutritionist that you're going to reach out for the overall care of your patients. And one of those things you're going to throw up in there and say, hey, at some point I'm going to need to feed this patient. What do you recommend? And then start that dialogue, right? And if you have any questions, that's the whole purpose of a teleconsultation call too, right? Ask somebody and talk through the situation. Have the means and the medical decision capabilities to work through it yourself. But if you have a lifeline, call somebody. So decreased core body temperature. So the generalized peritonitis, intestinal obstructions, bowel discontinuity, ileus, all of those things are just the stomach isn't working normally. And so don't put food into it. That's like, it's not a trick question. It's, hey, that looks concerning. Even if you just consider it, work through it, talk to somebody, consult, and then figure out if you do it. And if you decide to try it, you're going to go slow, just like you would with anything. Put the tube, put a little bit of fluid in there and see what happens, right? If you've secured the airway, if you're worried about that. What systems do you guys have available to phone a friend? What's out there? Where you guys are? Do you have local hospital? Do you have higher headquarters? Do you have friends? Like who could you reach out to and call? That should be part of your med intel plan for where you're going into an austere environment is who do I consult? Who can I call? Okay. Top cover's good. Phone, satellite. Yeah, but you have the means to make the call, but who are you going to call? And do you have a list of phone numbers? Like who would you call and how would you call them? Right. Sometimes being in the military, in the U.S. military, there's a process for turning the phone on and reaching a local number to wherever country we are to call back DSN to another military location or call to a commercial. Like there's a process that you're going to have to do, some kind of gymnastics with the phone to make it call whomever you need to call. All of those instructions should be spelled out and put into form. Like, hey, if you're going to call a military treatment facility, here's the number and here's how you dial the number. If you're going to call a commercial civilian, this is how you call and this is the number you're going to call. If you get a chance, we're kind of getting into a little bit of meta intel, but if you're going to be in a remote location, you need to have all this worked out because chances are you might not be the person making the call. You're going to have a teammate that you're going to go, hey, get GI on the phone or call the hospital in this country and ask for Aebhric or Rhod, right? You're going to have somebody's name ideally and say, hey, call and ask for this person. And when that person, who are they going to answer? Who's going to answer the phone and are they going to answer? Those are things that you need to work out. So when you do have a critical patient like this that you need to feed, somebody's going to answer the phone and help you out, even if they're the ones working Google while they're on the phone with you. I mean, in austere environments, absolutely work through things like that. So you want to go through the next one, next slide. So the CPG covers the nasojejunal feeding tube. It mentions that quite often, and this is based on a hospital. And they also mention that this is going to take place at a roll 3 or higher. So most of us are going to be at, roll 1 minus, maybe in the proximity of a roll 2, and they don't really consider placing a nasojejunal tube. That's a tube that basically is going to get through the stomach into the jejunum. And what that does is that avoids all of those complications for somebody that has an unsecure airway, difficulty breathing, and all those, because the stomach isn't going to back up. If they've got a hiatal hernia, that's going to restrict. They're going to have esophageal reflux. You're going to have gastrospasms. All these different things that could complicate feeding in somebody that's may or may not has a complete secure airway. You just put a tube down their esophagus. So if you get it past the stomach, you reduce a lot of the secondary complications that you would get with trying to give enteral feeding to a patient. But you would have a second tube that would go into the stomach so that you could hydrate the patient. You could also release the distension if there's any air trapped in there, if there's excessive acid or any kind of reflux complications, you could drain that out of the stomach through an NG or an OG tube that's sitting in the stomach. Does that make sense? Is that something that is completely foreign to us? Is there a complication that people have had doing those? I know the diagram's there, and we talked about it a little bit during the pre-meeting. I've never placed an NJ FT. That's done used under fluoroscopic guidance, usually under some sedation. But you need to be able to drive that tube and get it through the stomach and into the jejunum, which half jokingly said I've never done that intentionally with an NG or OG tube, but I've definitely put one in the stomach. It takes practice too. Just a kind of show of hands, how many people in the group have actually placed NG, OG tubes in training or in real? Okay. 1, 2, 3. Okay. Yep. It's definitely an art, not straightforward. You got tricks. Does anybody have a good trick that they'd like to share with the group? Like curling it or sipping water, or go ahead, Mason.
My little what do you call it? Position is if I intubate a patient, I never get rid of the glide scope until I put the OG or NG in, because it helps a lot to put it in. And it's the second you get rid of it, it's the second you can't get it without the scope.
I like it. That's good. Well, you're already there, right? So you place the important tube into the trachea, secure the airway, and now you got the rest of the time to play with the rest,
And you can use the scope to lift up the tube and the whole pharynx, then make sure you can get it right into the trachea, the esophagus instead of the trachea.
That makes perfect sense. Great point. It's awesome. Any other tricks, tips somebody's come across that would be helpful for the group? No, that's a good one. Thanks, Mason. Go ahead, Mom.
Yeah, so one of the things I remember from nursing school, before we put the tube in, it's better to measure the length of the tube from the nose to the ear and all the way down the tip of the tube, all the way down to kind of the belly area. So stomach area, that where it should be. So we mark the end on the edge of the nose. So we know how, when we kind of putting it in and reaching that mark, we know that we are in the stomach now, and we don't need to kind of keep going in an approximate distance to we know the tip of the tube is in the stomach. So it's kind of for the measurement.
Yeah, the distal spot I use is the xiphoid. Start at the nose, go around the ear, back down the throat, and then down to the xiphoid process. And that's I should not go past the stomach with that. I should at least get to the stomach. And that puts us in there. No, it's a good point. Good for measurement. Good recommendation. Throw the tape around there so you know how far to place, how far to advance the tube. That's a good thing. I've done where I've wrapped the tube, the end of the tube around my finger to kind of curl it so that when I stick it into the nasal cavity, it comes down, and I have them sip a glass of water if they're awake, if they're conscious. If they're not conscious, I've opened their mouth. I've used a bite block so I could see it, and then I'll use some type of forceps to stay, to keep it in the posterior pharynx. As long as if they're unconscious, they don't have a gag, I'm able to do this and make sure that it stays back and it just doesn't curl up in the back of the pharynx, which is a complication. But if they're awake, you have them sit up and sip water, and that swallowing of the water kind of keeps the tube in the back of the throat, suppresses the gag reflex, and allows it to get past the trachea into the esophagus.
Yeah, Bill, Alfredo, and Elizabeth have got a couple up in the chat.
Go ahead. Yep, swallowing while they're awake. Okay. Yep, to guide it. If they're unconscious, I can use the McGill's to guide the nasogastric tube, and then using the syringe to confirm placement. Absolutely. Yep. No, those are good. All right. So how do you calculate the requirements. Now, a lot of this, the easy answer is call nutrition, consult somebody, and talk through it. They're able to give you from just vast amounts of experience. One of the different weights that they talk about in the CPG is ideal body weight and actual body weight. When you're calculating your weights, how many kilocalories per kilogram per day when they're calculating the requirements. So we won't get into the details of the numbers that are in here, but you want to understand, if you've got a fit patient, somebody that is large and muscular, and their BMI is greater than 30, then you want to use their actual body weight in kilograms. But if you have somebody that is obese with a BMI greater than 30, then you want to go with ideal body weight. So you're not overfeeding your patient that is obese versus somebody that truly has the musculature that requires a higher energy requirement for a sustainment and recovery. I mean, that concept is not something that I've really thought about, but bringing it up into the context of this CPG, I think it's relevant in that there's two different requirements. Because if you use a 75 kilogram patient, that's probably going to be, depending on the time in the service and the sex, you're going to have most of your patients are going to be in that 75 kilogram, but you're going to have a good number of people that are up into the 100 kilogram, maybe even plus, right? Just because of their body status and how musculature they are. Yep. So when you're looking at total calories and protein, though, they count those as different. So how many calories of the total amount should be protein in the supplementation? Has anybody done parenteral feedings in the field? In the hospital, I've always consulted, so I've never done the math myself. When I'm taking care of a neuro patient in the ICU, I consult nutrition and I let them do it. I'll look at the orders afterwards, and they all make sense, but I don't do them myself. And in the field, I've never had to feed anybody. I've never sat on them like a US person or a partner force. I've never sat on them long enough that I needed to feed them in the field. Has anybody got that kind of experience? No. Okay. All right. So we're going over theory and concepts now. So this is good. Put this in the proper perspective, right? I encourage you to call and talk to an expert when you're doing this. All right. So yeah, some of the chats, Dimitri put in there 25 to 35 kilocalories per kilogram per day, with the stress factor, 1.5 to 2 grams for protein in a kilogram per day. Yeah, only in the hospital setting. Yeah, most of this is based to the hospital setting, but they're giving you information for the field. Now, if you've got a patient that you're only going to sit on for 3 or 4 days and you know that they're going to need nutrition, but they're not going to be with you, you're going to be moving them, it's in the contraindicated. Is it absolutely contraindicated? No, because based on your situation and your capabilities and staffing, you may be able to initiate by placing the tube. Once again, it's going to be an NG and OG tube, not an NJ feeding tube. It's not going to go past the jejunum. So that's not something that we're going to do in the field unless you're just carrying a tactical fluoroscope, which I've never seen, right? That would kind of be awesome. And you can't use ultrasound because ultrasound, there's going to be too much air in the belly in that area. You're not going to be able to guide or see the tube because of all the gas, the air is going to completely obscure your field. You're not going to be able to guide that tube anywhere. So in the different methods that you're going to give fluid, when you actually give them, you give them, there's continuous feeding, cyclical feeding, intermittent feeding, and bolus. I would only consider bolus feeding because the others require some form of pump that I've never used, never had in the field. So it's only bolus that I would be giving, where I would place the tube, the NG tube, and then I would use a 20 or 60 cc syringe to actually give a feeding in a bolus form. That's how I would do it. I've not done it in the field. Any comments or suggestions or thoughts on that? Anything that sounds crazy or something that we should consider? I think if I was working with a local clinic or a local hospital where I had, say, a partner force that I was able to put into their system, depending on where they were, and I would bring up a feeding requirement. A lot of times they put that on the family, to go purchase the food and bring it back, or, purchase med supplies and bring it back, depending on where you are. Is that way up on Killy, Aebhric?
Definitely. Yeah.
Yeah. So if you bring it up as the remote provider, bringing a local patient to a local hospital, asking them about, hey, when can we start feedings? They may have a fluoroscope there. It's likely. I know a lot of times being in the military, I've thrown a stethoscope around my neck and I've walked in like I own the place and made it work. That universal access pass that you're able to get in there and make things happen just by asking the right questions and using the right terminology. That's always been helpful. But you might be able to use some local equipment where they call it experience and attitude and make it happen, kind of figure it out.
And certainly in this part of the world as well, the expectation is the family will go out, purchase the food, come back, feed the patient, bathe the patient, do all that bedside care. So there's certainly no sort of nursing backup on that front. That doesn't matter whether it's a local type clinic or one of the big hospitals in one of the main cities out here.
Yeah. So volume-based versus hourly rate. Once again, I would only feel comfortable doing bolus, meaning I would figure out the volume that I needed to give. I would give it slowly. That would be my inclination without prior experience in this, and basically getting directions from somebody that's talking me through this on the phone. I think starting out with 20 milliliter an hour and doing that over a certain period of times, that would be more incremental or cyclical. I would definitely be very open in the first couple of boluses to watching how the patient responded. How well did they tolerate the feeding? How well did their stomach handle it? Did they distend? I'd also look at all the other things that I'm doing. So I would have a catheter in for urine output. You have to look at bowel movements of a patient too, depending on how sick they are, if they're able to. Those are factors that you're going to have to deal with maintaining a patient over days. If you have a severe patient that's, severe trauma, severe burns, or severe TBI, they've got their requirements. You're going to have to monitor that and everything else that's going on. Nutrition is one of 1,000 things that you're going to have to be proficient in to figure out, or the ability to work through it. Those are things I would consider. So they mentioned in the Austere ICU, you want to anticipate frequent interruptions with movement of your patient. Like you're going to get them from location A, B to C to D through the process. And that's why they say that if you're not going to sit on this patient for 5 to 7 days, then you might not consider that's in that possible contraindication to starting enteral feeding for your patient, if you're going to have to do the frequent stops and starts for that. Movement is a dangerous portion for the patient. You worry about lines becoming dislodged and misplaced. And then if you're not confirming placement of the line, if you don't have the ability to confirm the location of it, then you could invite possible complications that just make everything worse for your patient. Anything to add? Okay. Excellent. One of the things we talked about is making sure that the line is patent. When you're running fluid through an NG tube, it's sufficient enough to move that food, but you want to flush the line the first time before you actually push any fluid. You want to push whatever food you're going to be giving the patient, and then once you're done, you want to flush the line again with at least 20 cc's. And then they suggest for line maintenance that you flush it every 2 hours to make sure patency. You can do this for hydration supplementation. If you're limited on IV fluids, you can definitely give fluid to the patient that way. So that's another way. And then basically this is part of your Hitman and your nursing standards for monitoring. So you're going to put it on a chart. You're going to track it. And if you're giving, wake up criteria for your teammates that are non-medical, that are maintaining the patient while you get some sleep, or whether you're doing, some other task, you want it on the list to verify that they know how to do it, that they do it, and that you're tracking it, and for trends, if any complications. If they notice that there's some resistance when they're flushing the line, if there's any residual when they finish the line, you want to aspirate to make sure that it's still there. If there's any complications, you want to educate your teammates that are non-medical, that are assisting you, what to look out for, what to see, what to look out for, and definitely when to wake you up when there's complications, if they're providing some kind of interval care while you're resting. All right. So how do you tell if there's any complications? Resistance into food, aspirations. A lot of times it can be placement. That tube, your stomach's it's not like the big balloon. So it collapses on itself when it's empty. And so if you get stuck into a fold and you're aspirating on that, it's going to, kind of close off the end of the hose. So that's going to be a complication. I think this reduced feed rate, you're going to keep suction on there. So gastric juices don't build up. But if you're running flow through a pump, and it starts backing up, or it starts giving you warnings, that's an indication that your line may not be patent. It could be a kink in the tube. It could be a misplacement. It could be a fold. Any of those complications that are stopping obstructing the normal flow. We talked about this in some of the contraindications, like if your patient develops diarrhea as opposed to this, if they start vomiting, if there's any complications, signs of distension, those are problems. You want to switch. Generally, my first response is going to be to hold feedings. I'm going to hold them until I can figure out what's going on. And then when I start them back, they're going to be slower than before. Anything to add, Rhod?
I would say NG and just oral rehydration is best in the minimum better best, even though the CPGs are saying that IV solutions are better. Yeah, this is primary. and everyone should get this.
Okay. Dimitri brought up a good point saying feeding to gravity. I can see that, but if you're doing this through an NG tube or an OG tube, you're going to put your 20 to 60 cc syringe into the end of the tube, and you're going to have to manually push that. So it's only going to flow to gravity if you have it into a higher bag and you're letting it flow in kind of like an IV or blood. So if I'm misunderstanding your comment about the gravity feeding.
Not gravity feeding, just if this is what you need to do to get your just hydration and let alone feeding, then it's two birds in one stone.
Oh, no. I'm talking about in the comment section. Dimitri brought in a comment, says, I would prefer to use gravity while giving a bolus. That's going to be a closed system. I don't think it's going to flow to gravity. I don't know. It's like I said, I've not done this in the field. I mean, I've put a tube in and I've run fluids, but I've not fed somebody in the field. So I could totally be off.
You're talking about with an OG or an NG?
Yeah. So if I may just intervene a little bit.
Yeah.
The whole idea is it's related to both feeding and hydration. It's usually done not with NG tubes, so nasogastric or stuff like that. It's usually done with PEG tubes, yeah. So PEG feeding, but I could see it work. Yeah, you could place the syringe up top without having to push. You just put the necessary amount with less thick fluid type feeding.
Yeah.
If you know what I mean. And then you actually use gravity. Yeah. So you improvise something where, I don't know, a support a bit higher, and then you let gravity do its work. And that will actually give you a little bit of space to move and will not keep your hands occupied. That's what I meant. But it helps with less, because, there's like, if you're feeding fluids types and the thickness is different. So it usually works with the less thicker ones.
Okay. Well, I suspect that you could even dilute anything, right? But then you get into your volume.
You can use dilution. Yeah, you can use dilution, but it's kind of hard to calculate. Usually the ICU doctors would tell you exactly, or like nutritionists, they will tell you exactly how much can you dilute, the dilution stuff.
If you're using a syringe, you have to take. If you're using a syringe, you have to take the plunger out. So leave it open to the top, and then it can just fall in by gravity. If you leave the plunger in, it won't go through. But if you take the plunger out and let it just kind of act like a funnel, then it does work.
Yeah, basically, you take the plunger out. So you don't push. You take the plunger out. You put the fluid in. I don't know. The requirement would be, let's say, 30 milliliters or 60 milliliters at once, and you just let gravity do its stuff, do its job.
Interesting. I wonder how intra-abdominal pressure would affect that. I mean, if your patient's able to move, or you got to sit them up to a certain extent.
You'd have to change the height above. But I mean, like generally speaking, if you put it up on a pole or whatever, it's going to be, it's going to have 100 centimeters, like maybe 100 centimeters of water worth of pressure. So you're not gonna have any trouble unless they have like severe compartment syndrome, and then you got bigger issues.
Well, I'm not talking about inducing it. I'm just saying if it's somewhat present and you don't realize it until during the feeding kind of thing. Like even if you just flex a little bit to move or stabilize your core, does that change that intra-abdominal pressure to?
No, that's what I'm saying. When you look at intra-abdominal pressures, compartment syndrome develops, I think, like 12 to 20 millimeters of mercury, which is like the equivalent of maybe 30 centimeters of water. So if you have the syringe like, 50 or 60 centimeters above the stomach, you're going to be overcoming any pressures unless they're very severe.
Okay. Yeah, this is a new area for me. So yeah, thank you. It's awesome. Great input.
Yeah, and I've also seen this done with both conscious and unconscious patients. So
okay. No, that's definitely worth considering. That's awesome.
That is an AI generated top 10 tips.
Okay.
So I using Google, is it Notepad? So you drag and drop your document in there and you can ask it a question. And I said, pick out the top 10 as emphasized throughout this CPG, number 33. And this is what it came up with.
Interesting. Okay. Do you want to talk through it or?
Not particularly. No.
Well, actually, there's some good information in here. He sent this early this morning, and I was going through looking for, just the key things to talk about, and this was already done. So I stopped looking, and it was good.
I think what was quite nice having done it was actually looking then back at the slides that Aebhric had done a week ago, and how they corresponded across the board. So that was reaffirming, even if there were lots of numbers and stuff in there that this knuckle dragging paramedic didn't quite understand.
Yep. No, I thought it was good because it kind of gave good summarization of it. The hypocaloric, like number 6, hypocaloric approach, basically said there was previous practices of overfeeding critically ill or injured patients are associated with no nutritional benefit, but significantly increase the risk of adverse events. And so, giving a hypocaloric slow trial, the concept of let me just give a little bit to see how the patient tolerates it, basically that decreases your risks, your secondary risks, while, taking advantage of the benefits of feeding your patient early. So I liked that comment. And it basically gave the different caloric requirements for a trauma burn and TBI patient, which basically talking about protein wise for a 75 kilogram patient is somewhere between 112 and 150 grams of protein per day. How you calculate that out based on whatever formula you have. And then for 100 kilogram, that's 150 to 200 grams of protein for just isolated trauma burns and TBI patients. They talk about glutamine, which I've not used in the field. So it's mentioned in the CPG. I ran through there. I don't have much experience using it, but it is weight-based dosed. Only benefit status post-surgery for isolated severe burns or patients that have HIV AIDS, and it helps them with weight gain. So not generally our patient population. So no, I thought it was a helpful little thing that was put together. I didn't realize you did it through Google AI, which
get the right questions.
Good on it.
If you don't ask the right questions, you don't get the right answers.
That's yes, facts, truth. Good deal. All right, Aebhric.
So I nicked this from our field guide, and for those of you that have it, we do mention it. The 3rd edition will have a bit more of it, but you can't get through our prolonged field care without looking at nutrition. It's pretty important. It's in the sheep vomit mnemonic. But any questions on nutrition? And if not, we need to sort out next month's chat. So if anyone has any questions, let us have them now. And Dimitro, go for it.
Yeah. So my question would be, because I've been through the nutrition part of my studies, and it does say at some points that the indication for enteral, for example, nutrition would be if the patient is unable to meet the metabolic demand by oral consumption for more than 7 days. So in a prolonged field care situation, how long can we keep the patient until we actually start any sort of type of, be it enteral or parenteral, but I presume enteral nutrition? So what would the indication be? What would be the time? I know we started early. The earlier we start, the better. But how we determine when early is okay to start that? 24 to 48 hours, over 72 hours. I mean, I know it's dependent on each and every patient because each and every patient is unique, but like guideline would be what exactly until we actually start the nutrition?
That's a great question because it's more of a so what, right? It's a so what question. So what do I do with all this information? The reason why I haven't done enteral feeding in a patient in the field during my deployments is because I can evac them quicker than the requirements. So if I'm going to see a patient or have a patient that I'm going to sit on for more than a week, then I know that patient needs nutrition to help improve their reduce their recovery time. And so once I know that the patient needs the enteral feeding, then I need to start it within the 1 to 24 to 48 hours. I've not had a situation where I've had to sit on that patient for a week. And so if it's less than a week, it's like you have to decide at what point can you start that feeding that isn't going to be an unnecessary complication in the movement process of getting that patient from where you are to where they're actually going. Does that make sense? So you're weighing pros and cons. They're going to benefit from the nutrition, but is it going to be an unnecessary complication through the evacuation process?
Yeah, this is what I was thinking about because in my line of work, I am also remote as well. Mm-hmm. I can evac them fast, thank God. But even if I would have to start nutrition for a patient that let's say I have over 72 hours in my sick bay, I would probably start with parenteral in my opinion. That would be my first choice because it's less need for interruption. I know there are catheter-related infections or occlusions, all of those things, but that is my opinion. I could start it actually early and it's not really dependent on the gastrointestinal function, in my point of view, because I might have that patient, let's say, under sedation, and that would be my first go-to. And then I would go, let's say, as you said, if I have him more than a week, then I would think about Enteral as well.
Right. So then what do you have for parenteral and nutrition? What do you have to give them calories?
Well, this would be a complicated one because I wouldn't have that much. I would probably have something in to keep the glycemic level high, but I wouldn't have the calories or proteins, because usually in the field you don't really have that. That's the whole point.
Yeah. I'm looking through the CPG to see. Yeah. So parenteral, the order form, it lists, you got electrolyte packages, you got sodium packages, potassium packages. You can do additional orders. Yeah. So I agree with you. If you are only going to keep them for a short period of time, starting them on parenteral, if you are able to do it, would probably benefit them. But do you have the parenteral nutrition available to start it, right? Because you're not going to keep a patient for more than 7 days. It might be better for you to keep parenteral nutrition, knowing that that is logistically going to be easier for you to start on the patient to help improve their healing, reduce their healing time while they're being transported, right? You could make a case for that, right?
Yeah. That was my question mark, let's say. And thank you for giving me the guidance.
Yeah. And so you have to, like, the case is, how many patients have you had that you think would have benefited from starting parenteral nutrition during the evac process?
Well, I was lucky enough not to have that many. I think.
But how about anybody else from your location? So these are all things that you go into the pros and cons, the risk management process. If you've had 10 patients and they would have benefited from doing this in a short period of time, then what is the cost of keeping parenteral nutrition on site for those type of patients? If you don't have an N higher than 1 or 2, well, then it might not be beneficial to do it. It's kind of the same argument for keeping antivenom in certain locations, Well,
that's true. I got antivenom offshore. I mean, I've seen that, so it is true.
Yeah. So you just have to figure out logistically, because, it costs money. And so somebody up there is counting beans, and they're figuring out where is it going to benefit, the company, the people, the population, you as a provider. All of these things are factors. And so you just have to make a case what makes the most sense. If you don't keep a patient, if you're not going to sit on a patient for at least a week, then nutrition requirements may not be something that is necessary. You should consider it, but once again, it's hard to make a case for something that doesn't happen very often.
Okay, so I would actually consider nutrition, for example, in a field hospital, let's say prolonged field care in a field hospital or clinic, stuff like that, instead of actually, 2-3 days where you can get medevac or help arrives under any form.
Yeah, the benefits of 2 to 3 day evacs are the fact that nutrition is rarely going to be a concern that you need to really deliberate over. That's just the benefit of not sitting on a patient that long.
Fully agree with that statement.
Yeah. But then there's always going to be the reality always gets a vote, and the helicopter that would normally get your patient out may not come because of weather or whatever. So you might end up sitting. So then you got to get creative. And that's where you need to know, can I put an NG tube in the patient? Can I give them this way? So what are the other things? So nutrition is something that we need to know. I mean, above my baseline level of carrots are generally more nutritious than hamburgers. I have to somehow be able to sustain a patient and recognize when I'm going to need to do that. No, great points.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.